Good afternoon, everyone. Thank you for joining us today for the next in our series of Pathways to Prosperity webinars hosted by Vanguard Communications. Today's webinar is titled Patient Transparency, Answering Tough Questions About Surgery, and will be presented by Dr. Jaime Arruda. If you have any questions during the presentation, please feel free to chat them in the sidebar to the left of your screen, and we will try to answer the Q&A part of our webinar. We will also have an ongoing Twitter feed with the hashtag Pathways by Vanguard if you'd like to join the conversation that way. Dr. Jaime Arruda is a gynecologist and surgeon at the University of Colorado Hospital. She has special practice interests in exercise and health, endometriosis, fibroids, BRCA patients, and as well as minimally invasive and robotic surgery. Dr. Arruda has been named one of the top docs for the past 3 years by 5280 magazine here in Denver in the field of obstetrics and gynecology. This prestigious listing has recognized Denver area physicians cited by their peers as the top in their field for more than 20 years. She has also received the University of Colorado's OBGYN Resident Teaching Award and the School of Medicine's Chancellor's Teaching Award. We're very excited to have Dr. Arruda with us today, and I'm going to leap ahead here to pose the 7 questions commonly from patients. That is the context for our presentation today, and then Dr. Arruda will take it from there. The 7 questions, of course, are the ones before you. How many of these procedures do you do every year? What if I have a complication? How frequent are your unexpected procedures? What is the typical hospital stay associated with this surgical procedure? What is the infection risk? Who do I call if I have a problem in the post-op period? And finally, number 7, what is the follow-up plan? With that, Dr. Arruda, please take it away.
All right. What I came to this talk to ask is, how do patients find a good surgeon? And this is remarkably difficult to figure out from a patient's point of view. So I started out with my partners and asking them, what do they think are the qualities of a good surgeon? And this is a little bit like playing The Price is Right, but the very first thing that all of my partners said that made someone a good surgeon was a large volume of cases. It was really interesting. People didn't talk as much about the quality of cases as they talked about the volume of cases that surgeons did, and then use that as an extrapolation to mean quality of cases. The second thing that people really brought up were the complexity of patients that were taken by a surgeon. So anybody in my field can pretty much do a hysterectomy on a nice little BMI of 15 or 20. But most of us who end up taking more complex patients, so the BMI of 50 with hypertension and diabetes and 50 prior surgeries, the surgeons who take those patients, my partners felt like that was a sign of a higher quality surgeon. Obviously, we all want surgeons who have good surgical outcomes and then in similar association, low complications. And then surprisingly, a lot of my partners who have also themselves been patients felt that a quality of a good surgeon had a lot to do with the ease of pre and post-op care and the experience, if you will, that the patient had with our surgical intervention. So it was remarkably difficult when I acted as a patient looking online to figure out if there was any data, either online or in person, over whether or not a surgeon was high quality. And these are some of the barriers that I found that really hold up our patients to find out anything about their surgical quality. So the first thing I found is that despite searching sort of day and night with all of the things I know as an OBGYN surgeon, there's no online information available about how many cases personally a surgeon does. So it's really hard to look online and say, oh, let me look up Dr. Arruda. I see she did 75 hysterectomies this month or this year or in this decade, and here's how her outcomes were. There are also no published data online for patients to see on individual surgical complications, which is a pretty big deal. And many referrals are sort of word of mouth, i.e. my primary care physician always refers patients to this surgeon, or my friend had a good experience with this doctor, or my mother-in-law said this or that. And I'm going to talk today about if there's any value in that and if there's any data to support that. One big deal, especially in the Denver area, is that your insurance may not cover the best surgeon that you need. And that may not be a big deal if all you need is something simple that everybody does. But if you have something fairly complex, I would say it might be important to go to the best person in that field. And then oftentimes your medical problems may necessitate a higher level of care. We have a lot more flexibility at a university hospital or at a big hospital to take care of just about everybody. But if you have a complex medical history, you may not want to have surgery at your local hospital right next door. So just in looking over what is available online and who has access to it, I found that some hospitals do publish their case numbers and complications. It's very interesting in my field, so in OBGYN, almost no hospitals publish their case number and complications. And I looked through some of the major surgical centers in the United States who I know from hospital-based data do a lot of hysterectomies, for example. And even those hospitals do not publish their gynecologic surgical numbers and complications online. The best site I had seen was the Cleveland Clinic site. And even that center, which is a huge surgical center, only publishes numbers for about 8 of their most complex procedures. And interestingly, it's kind of a smattering of data. So if you are unlucky enough to need a pulmonary resection at the Cleveland Clinic, you can click on their webpage and you can click on pulmonary resection and you can see how many cases they did in 2005, 2006, 2007, and so forth. And you can see what their published mortality and morbidity rate, meaning how many complications they had and how many people died related to the procedure in each year. And then they give a little smattering of information as to, for example, why people had the surgery and how complicated their medical history. But it's pretty thin. And as a patient, I think you have to look pretty hard to get that information. As a hospital, we have access to quite a bit more quality data information. And what we use predominantly in the United States is called the NSQIP, NSQIP, which stands for National Surgical Quality Improvement Project database. Interestingly, hospitals that participate in the University Hospital Consortium also publish their surgical outcomes under a separate UHC database. And just a little bit of history on NSQIP. It actually started out in the 1980s when many of you may remember the VA hospitals, some things never change, had been getting some pressure with regard to why their surgical outcomes were seemingly worse than the rest of the country. And so there was actually a congressional law passed that required VA hospitals to show their surgical outcomes in comparison to the national averages. But then when we looked more broadly, there was no published national average for the VA to compare their data to, if you will. So NSQIP was started way back then with a small group of hospitals coming together to pool their surgical outcomes. And now about 600 or 700 hospitals participate in NSQIP, so provide their data on surgical procedures. And for example, last year there were 750,000 or more surgical procedures reported to NSQIP. And the database is great in the sense that you can ask it just for example, hysterectomy outcomes, or you can ask it just for prostatectomy outcomes. And when you query the NSQIP database for your hospital, you'll get your own hospital's personal rate of, say, urinary tract infections after hysterectomy or complications from this surgery or that. You get very personalized data, not per surgeon, but certainly per hospital and per procedure. Interestingly, there have been a ton of studies that have looked at hospitals participating in NSQIP, and they've found that there's actually about a 69% reduction in deaths at hospitals that participate in this quality database, there's a 79% reduction in the overall rate of complications, and there's about a 71% reduction in surgical site infections in hospitals that participate on NSQIP. So the bottom line is, if you ask for your own surgical outcomes and then you get them, you can actually turn it around to make quite a few changes that will improve the quality of your surgical outcomes. And this is like one of those, GI Joe moments of, knowledge being the first step towards improvement, but it is indeed true in this area. What can patients use NSQIP for? That's a little bit less clear, because since they don't work as part of hospital quality, they can't access the database the way we can. But they certainly can find out if their hospital participates in NSQIP, and that might be a sign of a higher level hospital and interest in quality improvement. And then they can also use the surgical risk calculator to figure out their personal surgical risk. So I put that just here on this slide. The left side is just the NSQIP app, and then the right side is the actual surgical risk calculator. So, if I were a patient, I might put hysterectomy in the procedure, and then I'd put, they can't fill in all of those things. They may not know their ASA class and their emergency status and that kind of thing, but they can put a fair number of their risks in to see what the calculator gives them as a surgical risk. And I think that's an interesting tool for assistance in patients who are deciding on surgical quality. When you step back and look a little bit more broadly at what patients have more access to, you will start to see some of the more common online options for patients. And one we're starting to see a lot more now is called ProPublica. And I don't know if everybody's familiar with ProPublica, but essentially it's a nonprofit, independent sort of newsroom that, one way to look at it, it's sort of like the Angie's List for a lot of different services, government, business, medicine, etc. And I just want to read what the published mission is for ProPublica, because I think it's really interesting, and it gives the skew on how it's related to patient care. So the mission is to expose abuses of power and betrayals of the public trust by government, business, and other institutions, I'm going to put parentheses, hospitals here, using the moral force of investigative journalism to spur reform through sustained spotlighting of wrongdoing, which that kind of is the style of ProPublica. But this is what our patients are using to decide on surgeon quality. And so what ProPublica does for surgeons is provide each surgeon with what's called a surgeon scorecard. And that is sort of a calculation of a given surgeon's complication rate. And it is based on Medicare billing records for inpatient hospital stays from the 5 years prior to whenever ProPublica puts out its data. So the most recent one was put out in 2014 for the 5 years prior to that. It only covers 8 common elective surgeries, and it excludes surgery on emergency patients and transfer patients, which is frankly good for a university hospital because it takes out the cases that are probably the highest complication cases. I think issues with the ProPublica system is it doesn't really take into account the level of medical complexity of a patient. So for example, a community hospital might operate routinely on a bunch of healthy patients, and a university hospital might get 1 or 2 really sick patients that would throw off the numbers here. And then probably more importantly, it really does not address some of the most common surgical procedures in the United States. So I don't know if everybody's aware, but the most common surgery performed in the United States is actually the C-section. It is more commonly performed than appendicitis or than removing your gallbladder. It is the most common surgery in the United States. I think that deserves some level of quality availability for patients to see online, and that is, for example, not a reportable surgery in ProPublica. And this is just a snapshot of what the ProPublica scorecard looks like. To get this, all I did was type in my zip code, And then it brought up a bunch of hospitals that are in my area. So I picked the first one on the list, probably one of the A hospitals here in the Denver metro area. And you can see at this hospital, they have surgeons that provide knee and hip replacement, laparoscopic gallbladders, lumbar fusions, and prostates. They specifically mention that there are no high volumes for those other two procedures at the bottom there. And then, for example, for knee replacement, it looks like they have about 7 surgeons that do that procedure, and they're all kind of medium complication risk. And then they have one outlier who has a high adjusted rate of complications. And you can just hover your mouse right over all of those little black lines and find out each surgeon's name at this hospital and where their complication risks fall. The problem with this, obviously, is that if you're that guy over there in the red, there's no information as to, is that the person who takes all of the complicated cases? Is that the person who's newest out of training? Or is there really a problem with this person's surgical skill? So as you can imagine, there's been a fair amount of pushback from surgeons on the way this surgeon scorecard is being used. The other thing that's available online, as most of us know, are just the tons of patient-driven online evaluation sites. So these are things like Yelp or Health Grades or ZocDoc or almost any of those things that allow a patient just to get online, log in, and rate their doctor. Interestingly, some of these sites don't actually verify that you've been a patient of that doctor in any way, shape, or form, and some of them do. And then many of them also don't really do any verification that each entry is an actual different person coming from a different computer or a different login. So I was interested to know, is there any value in those online patient-driven evaluations of doctors that correlates with surgical quality? So interestingly, there was one study looking at this, and it was by this guy, Jeffrey Segal. And what he looked at was, could you use online doctor reviews to differentiate between high volume surgeons and low volume surgeons? And so what he found was high volume surgeons actually have some statistical differences than low volume surgeons when it comes to their online evaluations. They tend to have more online evaluations total. And then when you look in the evaluations themselves, they tend to have more text comments as opposed to just a 1, 2, 3, 4, 5 response. And high volume surgeons had a higher proportion of glowing or positive reviews and a lower proportion of scathing or 1 out of 5 reviews. We take this information to extrapolate that a high volume surgeon is also a high quality surgeon. I'm not sure you can necessarily make that jump off the bat, but I do think it does go to show that for patient-driven online evaluations, you can at least use those pretty reliably to find a high volume or low volume surgeon. Interestingly, there were a couple of polls, one out of USA Today and one out of NPR, but the USA Today poll showed that 1 in 4 patients currently uses these doctor reviews online as their only modality to choose a physician. And that kind of blew my mind. For comparison, about 98% of people use an online evaluation of, say, a restaurant to choose a restaurant, so I guess we're doing better than that. But the fact that 1 in 4 people goes online and that is their only way of choosing a physician is pretty impressive. The NPR poll also showed a similar finding that about 59 to 60% of patients, people who use NPR, so perhaps a different group of patients, said they thought that online reviews were either important or very important in their doctor decision making. So I think it's something that we need to focus on. I'll touch back on that a little bit in a second. So given these limitations, what advice can we give a patient to help them find a good surgeon? I think this is what I tell my patients, and I tell them this kind of in this order, given the data that I have. I do think it's best to ask around. Your best evaluation of the intangible components of your surgeon, like what is her bedside manner? How hard is it to schedule with him? Do you like the plan? is only sort of figured out by either asking around and or meeting the surgeon, figuring it out. The second piece of this is to check your insurance. Surgeons and hospitals in this day and age must be covered under your insurance. I had a patient this week who, for some reason, she's decided not to take on the health insurance that is required by Obamacare, so she's paying the tax, penalty or whatnot. And just to walk in the door to have an elective surgery for her is $29,000. I don't know about many of you, but I don't have $29,000 to throw away, and nor would I want to drop it at the front door of a hospital. So making sure your insurance covers is covering your surgeon and hospital is a must in this day and age. The third thing I tell my patients is it's probably worthwhile, if you want to increase the quality of your care, to go to the hospital where you already get care for your other medical problems. So we do a fair amount of cardiac disease at the University of Colorado, and it's really helpful if someone who's had a heart transplant or a prior cardiovascular procedure is being seen at the same hospital where we already have all their records. They need to be considering, is there a need for ICU care or higher level of care after surgery? Can anesthesia handle your case? Has their surgeon ever taken care of a patient like this? And are there additional things they need to be thinking of? And the next step, I do think, I tell my patients, go ahead and look online for surgeons with a lot of comments and some positive reviews. I think there is good data showing that surgeons with more comments and reviews probably take care of more patients, and this may be a surrogate for increase in quality. Obviously we have our patients meet the surgeon and make sure that they're happy with their bedside manner, and are you on the same page for things like post-op care, pain management, what to do if a complication occurs. There still are quite a few surgeons in the world who have their nurses or PAs do their pre and post-op care, and I think that's a little bit of a red flag that there might be a quality issue or their volume is a little bit too high. And then I always encourage my patients to seek a second opinion. A second opinion for a common, particularly OBGYN surgical intervention, should be relatively on the same page as your first opinion. It may lead you to think of additional questions you want to ask your surgeon, and I would be wary if one of the opinions is way out in left field from anything you've either heard from your primary surgeon or read online. Finally, and this is a little bit difficult for patients to get online, but I think they should ask their surgeons directly about how they handle complications in post-op care. It can sometimes be awkward to bring that up with a surgeon because it sort of takes away the sense of trust, like what happens if you make a mistake. But like I said earlier, most surgeons should be able to discuss their experiences with complications with some confidence, as in, yes, I've seen this before, and this is what I would do if that occurred in our case. Anyway, I was just wrapping up with one more slide, which is how can we as surgeons increase our online presence to attract more patients? As awkward as it may be, I do ask my patients to fill out an online survey at the end of each visit. I feel like oftentimes patients who have a negative experience would be more likely to get online, and I'm trying to capture as many of the patients who also have a positive experience. And I think that's an easy thing for patients to do and for me to ask. We do it by way of a card in their post-op paperwork that they can fill out, and then we also ask them to get online to Health Grades or one of the online sites to evaluate us. Our hospital participates in the NSQIP database, and I think one way for a hospital to increase their recognizability for quality care is to participate in that database. It can be stressful because now you're going to get your own data back and you'll see what your actual complications are, but I also think it's the only way to get better. We do quite a few things to streamline our pre and post care so that our patients are getting everything in writing and they know exactly what to expect, and they also know how to get in touch with us if they have a problem. And we use an electronic medical record with an email-based communication, so truly a nurse or me is checking it 24 hours a day and can get in touch with them. And then probably the biggest thing I've found, and Vanguard has helped a ton with this, is how to optimize the search engines for our website so that when someone's looking for a specific diagnosis, they find us and then they can find a link to how to figure out if they're getting a quality surgeon. It would be really nice to see a lot more online with regard to either individual hospital surgical outcomes or, better yet, individual surgeons' surgical outcomes. And I do think those things are coming down the pipeline both through Medicare and private insurances. And that'll probably be some of the next steps as our healthcare in the United States starts to become more centralized. So that is kind of what I have for slide presentations, but I am happy to answer any questions.
Thanks, Dr. Arruda. We have quite a few questions, so we'll start with this one, which I think is very appropriate for our audience. As doctors, nurses, healthcare providers, and healthcare managers, what is our responsibility for patient education? How far should we go? How do we best divide our time between data analysis and being doctors and providers?
Well, I think people are not so much dividing their time, but they are focusing on one or the other more commonly. I think we figured out that in surgeons, for example, you're not going to be as good a surgeon if you do 25% surgery and 75% patient education and research. And so I think people really do one thing quite well. On the day-to-day, though, I think you do spend a lot of time in patient education, and it goes a long way when they hear it from their surgeon themselves. I mean, there's use for PAs or nurse practitioners or whatnot, but really, if I'm going to apply a knife to someone's abdomen, they deserve to have heard what was going on for me.
So there's another question here about the NSQIP database, the National Surgical Quality Improvement Project database. Is it possible to have an insider or a friend at a hospital research that for you to get a little more inside information on a particular surgeon?
The NSQIP database does not break it down by surgeon name. So, for example, we will find out from them, your hospital has done 500 hysterectomies this year, and rate of urinary tract infection is 3%, and your rate of, post-operative bleeding requiring a transfusion is 10% or whatever it is. But it does not give you an individual surgeon's name and then their personal complication risk. And I mean, I think that makes it harder for patients to choose a surgeon because they don't necessarily care what the hospital risk is. They care what my complication rate is. And trying to get that pinned down to an individual surgeon is really difficult.
So it's the NSQIP is really only useful for comparing hospitals, not physicians.
That's correct.
Then if you can actually have someone get into the database for you, and I presume then that the database is accessible to anyone with the credentials to look at multiple hospitals, not just any one hospital they might be employed by. Is that correct?
That's correct.
Good. We also had a question about the ProPublica surgeon scorecard. What if I'm a surgeon who has an issue with my report? Is there any redress for that sort of thing in the ProPublica?
So I looked in that because I was curious, and they actually, the way that they do the surgeon scorecard is they actually have a series or a panel of physicians in that specialty. So for example, urology, they would have 5 or 6 urologists who then review the cases that are associated with that physician. And they are, at least online, very committed to transparency for the surgeon. And so they have a contact method for the surgeon to sort of see what's going on here. Because you're spot on, if you're a surgeon that takes higher risk patient, now all you're getting is this black mark on your reputation from an online site to be able to have some contribution. ProPublica seemed a little bit more transparent in responding to surgeons' concerns than, say, some of the health grades or the patient-driven ones.
And this is a related question. in that same vein, how do I, as a surgeon or a healthcare manager, respond to a patient who's concerned about Yelp reviews I feel aren't particularly accurate?
I think as a physician, our hands are tied in that way. Oftentimes we know something that occurred, say, in the visit that is not necessarily, like, so for example, a patient will come in and we will have a discussion. I'll offer her some options that are non-surgical. And then she'll be unhappy with my response. And then she'll get online and sort of ditch me on one of those sites. And I don't have an ability to respond online because of the HIPAA violation that would occur if I exposed her medical problems online, right? I don't know that we have a way of, as surgeons, of responding to the online sites that are patient driven. I do think we have some routes to respond to the ProPublica type scorecards.
And if I could, I would like to add, we did have a webinar on this very topic earlier in 2015, I believe it was summer, and that is on our website for any of you listening. If you are a registered user in today's seminar, you should be able to go into the section on our website with your username and review some of those the ideas we presented for responding to those kinds of reviews. Which leads us to another related question. You were calling Yelp a pretty reliably source of ratings of physicians given Jeffrey Siegel's study. So what kind of grade would you give to the to sites like Yelp? Is it an A-, a C+, or is online reviews of doctors D or F?
Before I researched this presentation, I'd have given them an F, because my impression colloquially is that I think dissatisfied patients tend to get online. Like my mom, she's going to get a free ticket from United Airlines if she complains to United Airlines, but when she has a good experience, she's not going to be like, yay, I had a great experience, I'm going to rate them online. However, when I looked at the data, it actually doesn't pan out that way. I do think Yelp or any of the, that Paul Seeger study looked at a bunch of different sites, not just one. The number of ratings, regardless of whether they were good or bad, was higher in high volume surgeons. And so I think if you're a patient, you know that you can reliably say the people who have a lot of comments or a lot of ratings probably do a lot of surgery. And that's probably all we can take home from that.
So to put you on the spot for a little bit here, Dr. Arruda, would you personally rely on Yelp or similar sites for choosing a physician or surgeon for you or a loved one as a factor?
I would look to see if there were reviews, yes. It's easy for healthcare professionals because we can go to work and just say, who's good at this? And then someone tells them what they look like in the operating room on a day-to-day. But I think knowing what I know now, I would certainly look to see, hey, has this person gotten reviewed?
Yeah. Here's another good question from one of the participants. If you are a surgeon with high complication rates, how do you explain them to potential patients? What do you say to them? And I'm assuming there's sort of a built-in assumption here, that is, some physicians take on the most difficult cases.
So I think that's why I would, as a surgeon, it's our responsibility to know how many cases we've done of a certain variety and what our complications look like. So, I mean, the first step of insight to that is to really look at what your complications are as a surgeon and say, hey, am I approximately on par with the rest of the world? And then if you're not, we have to look and say, oh, look, yes, this year I had a higher complication rate, but when I look at these complicated patients, I see, this lady had a BMI of 62, and this one had a, heart transplant before her hysterectomy. And you need to really be able to justify that your complications are indeed due to a higher complexity of patient care, and not just, I'd like to think that. And then I'm pretty honest with my patients if they were to bring that up, just to say, here at University Hospital, we take care of a little bit more complicated patients. And so, sort of in the vein of not turning people away who've been turned away from other places, we're willing to accept a little bit higher complication rate than the average. But I think it's important to be honest with yourself first.
What is your general philosophy towards encouraging second opinions?
If it is something that's going to make you decide whether or not to have surgery, and you have the cushion of time to get a second opinion, it is definitely worthwhile. I mean, half the time I give a second opinion and the patient ends up having surgery with me, and about half the time I give a second opinion and the patient ends up having surgery with their first opinion. But sometimes they just need to know, I feel like two brains are better than one in making this decision, and I've gone to see two different people. And I do encourage people, if they have the luxury of time, it's not something that's life-threatening or, they have to have surgery tonight, that a second opinion is worthwhile.
Very good. Okay. Well, we have another minute or two if anyone wants to submit other questions. Otherwise, we're approaching, I think, our time limit. I want to also point out that there is a wonderful blog on Dr. Arruda's website for department entitled something to the effect of seven questions that patients should ask about surgery, and they're very guideline for any healthcare provider, healthcare manager, in terms of being ready to answer really tough questions. So I recommend you to obgyn.coloradowomenshealth.com, and then look for the blog button in the navigation at the top. It's in one of the drop-down menus, and it's a very well-written blog, and one that I will use next time I'm considering surgery for myself or a loved one. So again, that address is obgyn.coloradowomenshealth.com. And you can see two other blogs written by Dr. Arruda and her colleague there, and I think they're one of the standouts in the world of patient education and online patient education, especially. There's a wealth of really good information for OBGYN patients and reproductive medicine patients. So it doesn't look like we have, oh, here we go, one more question. You have other physicians that you refer patients to for a second opinion. I think the implication there is, should you have, a list of a handful of other doctors that you feel comfortable sending patients for second opinions of any kind?
That is an interesting question, because I think some patients prefer to get a second opinion from someone who I think is good, because they've come to me and they trust me and they say, who else would you have operate on me? And other patients prefer to have a completely unbiased second opinion, and they would be wary of me referring them for a second opinion to someone, because they're going to assume that I'm on the same, on the same brainwave as that person. So I will often ask patients, do you prefer that I give you a name for a second opinion? Because obviously I would know people who would operate like me or might have the same skill set or the same head on their shoulders that I do. But if they prefer to look on their own, I try not to push it, because I think a true second opinion is often someone who's coming in completely unbiased to the patient.
And do you have any, as a follow-up question, do you have any suggestions on how you respond if that patient comes back with a report that the opinion was radically different from yours?
So a lot of times that will occur if they seek a second opinion with someone who's like way out in left field. And I never mind sort of acknowledging that. Like, so for example, I'll see a patient for something that's probably benign, and she's young and she has very few risk factors for anything cancerous, and then she'll go see a cancer doc across town who generally sees patients that are much sicker and everything they look at is cancer. And so I would never be afraid to tell the patient, look, you've gone to see a cancer doc, so of course they think you have cancer, but statistically, you don't give my opinion. But it actually pretty rarely occurs.
Well, that's good to hear. Okay, I think we are about the end of our time here, so thanks to everybody for participating today, and especially to Dr. Arruda for a very, very insightful presentation. Anyone who registered for this webinar will receive an email with access to a recording of it, as well as to past webinars. And if you've attended a Vanguard Communications webinar before, your password will still work to access the recordings. Be sure to take the survey following the presentation and encourage others to sign up for the webinars series, as well as for Vanguard's newsletter to learn about upcoming webinars and the Pathways to Prosperity series. Our next presentation is scheduled for March 17th, and it will be on healthcare security, a really big topic these days with some famous security breaches such as Anthem and the U.S. government and so on in regards to health records. Are getting more and more spotlights these days. So be sure to watch your emails for more information on that. Thank you again for joining us. This concludes the webinar this time, and have a wonderful weekend. I look forward to seeing all of you virtually on March 17th for our webinar on healthcare security.